Thank you
I
very much.
hope you can all see my screen. So Leo and Sarcoidosis UK, thank you very much for this opportunity. I feel really honored actually to be in the midst of so many patients who've taken the time to join this afternoon. So the brief for my talk this afternoon was really to speak about the management of neurological sarcoidosis. Now, I can't really start talking about this without paying real kind of tribute to the amount of changes happen within the pathophysiology, understanding the pathophysiology of neurosarcoidosis within the last 10 years or so. And this has certainly improved the way we manage patients with neurological sarcoidosis because we understand the condition better. And a lot of my talk is designed today to provide you practical views on management of neurosarcoidosis from my personal perspective, but also drawing on the small studies we've got within neurological sarcoidosis. There is obviously a dearth of the study scenario within neurological sarcoidosis. There are no randomized controlled trials to date. And there's, of course, an urgent need for us to understand what we've got to do with patients with neurological sarcoidosis, particularly people who are refractory to the current treatment scenarios we've got. So the goal of therapy, in any patient with sarcoidosis as an entity, but more often in neurological sarcoidosis, it's very important then to define what the goal of therapy is. First of all, I think when we look after people with sarcoidosis, from my perspective, and of course from perspective of patients who attend clinic, it is to identify patients who are at danger of poor outcome, i.e., so people whose organ function is threatened versus people we can actually wait to treat or perhaps monitor closely. There needs to be a distinction. The other goal of therapy is to improve quality of life. So we need to worry about how we are impacting the wider patient in terms of not only their sort of themselves, but also their families, their carers, and a number of other things which play a significant role in their life as an entity. Then, of course, the treatment scenario, as I said, the pathophysiology of neurosarcoidosis has now resulted in us understanding the condition better, but there's also a number of more patients who are being treated with potentially toxic treatments. So we've got to identify how we minimize those drug-induced toxicities within patient groups. And then, of course, very importantly, it needs to be very much a mutually acceptable situation, which is clearly defined to both the physician and the patient. So what I really think is that a lot of our treatments have to be really based on, not only based on patients' needs, but also on the preferences of patients and their treatments. The goal of therapy is much more complicated than just pharmacological treatment. It is also very important for us to define, before we talk about management of sarcoidosis, what the challenges to those management might be. This can be diagnosing neurosarcoidosis, I think, is a challenge. So a number of patients in this meeting would probably agree in that diagnosing their condition has been a significant challenge. That by itself places an important question as to what the clinical course of that patient might be. So the clinical course might be very uncertain. Sometimes neurosarcoidosis is found as an incidental finding. So in patients like this, what do we actually do? There isn't a defined treatment pathway, and it tends to be more art than algorithm in managing patients such as that. And certainly, as I said, again, no randomized controlled trials. So very much treatment is based on what an expert thinks, based on clinical experience and a number of case reports. So the challenges are, there are a number, but obviously we talk about each one of those aspects just as we go along. Now, I like defining neurosarcoidosis care as A, B, C, D. So it makes it very easy to understand this, and a lot of you can probably relate to this as well. First of all, it's assessment. So the A stands for assessment. So what is the symptom burden in a patient with sarcoidosis? What are the organs involved? So this is a very unusual entity. So particularly as a neurologist, I think it's a very unusual condition we treat because almost any organ within the body can be involved in patients with sarcoidosis. So it's very important not only to assess whether that patient has got neurological involvement with sarcoid, but essentially is their liver involved, is their kidney involved, skin and bones. So they can be sort of, the assessment has to be holistic. very important to then think about side effects. As I said, patient needs and preferences and carer support. Now, B stands for education. So, it's backing within the base of education, and also self-management, psychological support, and patient groups. We'll talk about that as we sort of come along in this talk. So, really important to educate patients on what their disease condition is. So, you've got to understand what you have, and then it makes it sort of much more easy to have almost a holistic approach to management. Psychological support, I think, is incredibly important. So this is a condition which is, it's life-changing for a number of patients across this call. Treatments and the interactions with a number of different specialities which you might see during the course of your illness, and hence that psychological support to manage this is, I think, vitally important. It also, I think it's empowering for patients to know how to self-manage their conditions. So, for example, being able to understand what a flare of sarcoidosis is, for example, or what a relapse is, and sometimes what an exacerbation in symptoms is and how they can self-manage these symptoms, sometimes is extremely important. And of course, patient groups such as what we've got at the moment, sort of, where we are currently, I think is perhaps very vital to the management as well. Now, C stands for complaints and comorbidities. So when we manage people with sarcoidosis, I think one of the most important things we've got to think about is what are the comorbidities that patient suffers from? So that could be diabetes, for example, or heart disease, or concomitant liver disease. So particularly when you're treating patients with both disease-modifying treatments and symptom-based treatments, it's very important not only to understand what the complaints are, which is, what are the symptoms, but also what are the other conditions that patient actually struggles with. D is disease-modifying treatment. So this is almost synonymous with management of sarcoidosis. So with this slide, what I want to do is to almost, talk about other things which might be important apart from the disease-modifying treatment, which could be, people having corticosteroids or steroid-sparing immunosuppressants or biologics and newer drugs. And I think it's only one, as you can see on my slide, it's just one segment of the conversation. It's not the entity. And of course, the center part of the slide is the multidisciplinary teams which look after you. So as a neurologist, I'm one spoke in the wheel, but not all of it. So really, I think it's important for that conversation to happen between the patient and multidisciplinary teams, whether that is your pulmonary consultant or your cardiologist or your neurologist, or indeed your physiotherapist, your psychologist, your occupational therapist. So all these people play a very, very important role in making your disease not only well controlled, but also, you reach a point when you can actually live with it and manage it really well. Now, the first bit is the pharmacological management of sarcoidosis. Now, again, I can't start describing the pharmacological management to you without actually telling you what the assessment of that decision to treat is, for example. So this is something which we run through in our heads with pretty much any patient who walks into clinic. So very important, as you know, the center of that is the patient preference. So what do you want to do with your condition? And we will endeavor to obviously manage it that way. First of all, I think, who do I think I would want to treat? So versus who do I think I want to watch with regards to treatment, obviously completely in conversation with you. So the first thing is, if you're symptomatic, for example, if you've had sarcoidosis for a number of years, undiagnosed, for example, and you've been really struggling with those symptoms, be it, whether it's multi-system or whether it is, neurological, it's very important to assess what impairment that organ function impairment is causing. You've obviously sort of, heard from the previous speakers about the multiple different parts of the neurological system which can be involved with patients with sarcoidosis. What I can say is that not every organ or every part of neurological involvement needs to be treated the same way. So people with cranial nerve problems are treated very differently, as you saw from previous talks about, people presenting with hydrocephalus or spinal cord involvement. So there's, the treatment differs depending on which part of your, not only organ in the body, but which part of your neurological system is involved. Is the condition progressive? So this is very, very important, I think. For example, somebody who's had an MRI scan, which looks the same, but it looks active with over the last, over 4 to 5 years, is not certainly somebody with stable disease. So that is something which is very important to recognize. So if you've got a scan which looks like it's not undertreated, and that goes on for years and years and years, it's still an undertreated condition. It's very important then to pick it up and treat it, because that could lead to progressive disease. And then, of course, there are also a number of entities within neurological sarcoidosis, which I recognize as a specialist, but also you as a patient that has got a low likelihood of remission. So very often we can almost phenotype patients with sarcoidosis and talk about what types of sarcoid are likely to respond less to perhaps my observation of patients in clinic when compared to people who are likely to be treated. Now, the other side of the story is also, I think, extremely important. So who are the people who we can just observe? It might be unnecessary for people to take, potentially toxic disease-modifying treatments. And there is a possibility that these people can actually be watched and we can monitor them. So the symptoms can essentially be minimal symptoms. So the symptoms can be sort of minimal, which can be very much in terms of low risk of danger, for example. There's no progression, or people with a higher likelihood of remission, for example, as I said, with cranial nerve functions. So these are patients who can essentially be watched within a clinical scenario. Now, treatment is stepwise within neurosarcoid. So treatment essentially goes step by step. So certainly very much in terms of how we look after people. Steroids, which you're all very familiar with, is usually the first line treatment for sarcoidosis. So the first time somebody is diagnosed with sarcoidosis, it almost becomes synonymous with the way we actually treat people. We would either give people oral steroids, or people could be potentially treated with methylprednisolone, either in an oral or an intravenous form. So that's something several of you might be actually very familiar with. Sometimes, rarely so within neurosarcoidosis, people would remit, or that might be sufficient to treat someone with sarcoidosis. Cranial neuropathy involving the facial nerve, for example, is an example of a situation where we would manage people simply with prednisolone. And you may not hear about any other treatment, provided you actually remain under observation and you don't need it. Now, very often, neurosarcoidosis, as you all recognize, perhaps is associated with a slightly different outcome to patients, say, with pulmonary sarcoidosis or other forms of sarcoidosis, where the policy might be that we just keep an eye, whereas in neurosarcoidosis, we tend to keep an eye less on patients, but actually actively treat people, because we know that the outcomes tend to be, in a vast majority of patients, poor just on steroids. So up the tree goes other treatments such as methotrexate, mycophenolate, azathioprine. So these are all treatments which, again, very familiar to a lot of people on this in this meeting. But again, that is something sometimes used because we need to escalate treatment onto something more severe. Or more kind of potent, but equally, it might also be because some people have got side effects to steroids. It might be that we don't want to carry on with high-dose steroids for a very long time, and that might mean that we actually move people up that treatment tree. Again, things which are becoming more familiar are TNF treatments, which is tumor necrosis factor alpha blockers, which are essentially what we move on to when people tend to be what we call refractory to the current treatment. So that can essentially be infliximab, for example, or other monoclonal antibodies such as rituximab, adalimumab, which is, or Humira, as you might recognize that, cyclophosphamide as a treatment. So really what I wanted to sort of highlight is there's a stepwise plan to treating sarcoidosis. So sarcoidosis, some people, as I say, require very little treatment. Majority of people with sarcoidosis need to go up the tree, but where up the tree very much depends on the phenotype or what type of sarcoidosis that patient, neurosarcoidosis that patient actually has. Now, what I'll do in the next few slides is to just show you some of the pharmacological treatments with patients with sarcoidosis. So this can essentially be corticosteroids, for example, which can be prednisolone and methylprednisolone, which are the mainstay first-line treatments, which has been used for over 60 years. So people with sarcoidosis have had prednisolone and steroids for over 60 years. There are a number of pros and cons associated with that particular treatment. For example, it's very familiar to a clinician, so patients recognize it. Clinicians are very familiar using it, including general practitioners. It's broadly effective, so anyone with any form of sarcoidosis would find that steroids is effective to some extent in those patients, not to specific problems, but to broadly, it's an effective drug. It can be very easily titrated. So, very often we give people treatment plans in clinic, which sort of say, you need to go up to a dose of steroids and gradually reduce it over the next few months. And most people can usually understand that. It's a very easily titratable regime to it. It's widely available. So, sort of anywhere, we treat people sort of, locally, elsewhere, it's widely available. So really, there's not going to be a dearth of people being able to prescribe that medication. It is quick acting. So very often it's life-saving in the initial sort of few weeks of treatment. And it's quite a vital part of that particular cog in treating patients with sarcoidosis. And of course, it's very cheap. So it's, one of those things used worldwide. If people are very familiar with it. Now, the other side of the story is that there are a number of cons associated with our treatment as well. For example, you don't, as I just said, monotherapy is, seldom sufficient to treat sarcoidosis of neurological origin. So you generally find that treating people for a long period of time is associated with steroid-induced side effects, which, again, very recognizable in terms of weight gain, or hypertension or diabetes, bony side effects, gastritis, psychological symptoms, all very, very familiar to a lot of you. Monitoring people with sarcoidosis, I think this is something, because steroids are so commonly used and they're broadly effective, I think people become less worried about prescribing large doses of steroids, but it's really important to clinically monitor people on steroids, not only due to the infection risk, but also that regular check in glucose, for example. So anyone with high dose steroids, as with a number of other conditions treated, must have their blood glucose checked every few weeks. They must make sure that their chronic control of sugars are properly checked in the form of HbA1c. And of course, very often forgotten is actually checking bone density for loss in bone on people on high dose steroids. Again, as going up the tree to methotrexate, which is the next agent, again, sort of becoming more and more of a familiar entity, titrated up from a low dose to up to 25 milligrams, always prescribed in conjunction to folic acid, which we give 5 milligrams a week, but in some patients requiring a higher frequency, it's water-soluble and usually prescribed on all days, excepting the day when people take methotrexate. Now, the adverse effects, as again, we go down the tree, does increase. So very important to clinically monitor blood counts, anemia, neutropenia, toxicity to the liver, lung sort of involvement with pneumonitis. It's extremely rare, but something, we must keep an eye on. And of course, very important perhaps to remember that it is not a drug which can be taken during pregnancy and breastfeeding. So really important in that counseling of people going on to methotrexate, not only to ladies on methotrexate, but also gentlemen who are perhaps going to sort of have a baby with their partners. Sort of very, very important to sort of think about when we stop that methotrexate before, and important to counsel people about the longer term side effects of methotrexate also. Azathioprine, again, started at low dose, can be titrated up to 250 milligrams. So usually we base it on 2 milligrams per kilogram, but up to 250 milligrams once a day. The side effects are not very dissimilar to methotrexate, slightly higher risk frequency of infection when compared to methotrexate in the general population, obviously increasing with age as well, and the monitoring which goes with it. Mycophenolate, again, a sort of commonly heard entity, people on a wide range of doses, so somewhere between 500 and 1500. So generally along the same lines, monitoring extremely crucial to liver and renal toxicity and infections. Again, this is a teratogenic drug, so very important to consider stopping it before conception, important also to counsel, from physicians' perspective, to counsel patients, but also from patients' perspective, very important to be aware of that as well. Now, the three treatments which I just spoke about right now, in addition to steroids, are pretty much what we describe the cornerstone of management of neurological sarcoidosis. Now, ever so often, we get patients who do not respond to the standard treatments with neurological sarcoidosis, either because of unresponsive or refractory disease, or equally because patients might also have what we would describe as intolerance to one of those drugs. Now, cyclophosphamide is a drug which, again, those of you who are sort of familiar with some rheumatological conditions like lupus might be aware of. So cyclophosphamide is a drug which has been used in the management of lupus, for example, for decades. For neurological sarcoidosis, particularly some types of neurological sarcoidosis, particularly patients who've got vasculitis presentations, or patients who basically got presentations of stroke but due to vasculitis, or a number of other entities like peripheral nerve disease due to sarcoidosis, in some patients, cyclophosphamide might be quite important to escalate to. The side effects, in addition to infection, but also include cystitis of the bladder, also negated by the concomitant use of other agents with cyclophosphamide to reduce those effects. Now, very often people ask, when we start people in therapy in clinic, but also it's sort of a question which very often comes up from clinicians alike is, what is the evidence? So, I'm on methotrexate. Is it a better drug than azathioprine, or is azathioprine better than methotrexate? Now, again, to reiterate that we do need, randomized controlled trials in order to look at these things. The number of patients we have, and also the diagnosis of this condition so difficult that it essentially makes it has been difficult to design these trials, but we urgently need them. But what information we have would suggest that there was a retrospective study which compared methotrexate and azathioprine as second-line treatment for sarcoidosis. So this is bearing in mind pulmonary sarcoidosis, not neurological sarcoidosis. And what was found was that both methotrexate and azathioprine both had the same steroid-sparing potency, with perhaps azathioprine group having a slightly higher risk of infections. Moving on to biological treatments, so biological therapies, which are becoming more commonly used among us to escalate patients to, would be infliximab, which is a murine IgG antibody. So it's given IV to patients, used for refractory neurosarcoidosis. And often due to the fact that you can have antibodies to infliximab, which reduces how effective it is, it's very much co-administered with methotrexate or mycophenolate or other immunosuppressants as well. Then adalimumab, this is not murine, this is very much humanized monoclonal antibody, or Humira, which again, those of you familiar with rheumatological conditions might have heard of, is also another treatment increasingly used in people we can't use infliximab in due to antibody formation or due to intolerance or other factors. And rituximab, which is an anti-CD20, which is again a form of antibody treatment, which essentially we do use in other conditions, also can be used in sarcoidosis. Now, there are newer drugs for refractory sarcoidosis. None of these are licensed in the UK, but certainly we do have them in our armamentarium to kind of use them in people who are refractory on an individual basis by special funding measures, such as Janus kinase inhibitors, IL-6 inhibitors. So these are all based on our knowledge of the pathophysiology of neurosarcoidosis, and the mTOR inhibitor rapamycin. So these are all drugs which are sort of more and more sort of coming into sort of use in people with refractory sarcoidosis, although the understanding of these in a larger scale in people with not only neurosarcoidosis, but generally in sarcoidosis has got a little way to go. Now, in the interest of time, what I'll do is I'll just sort of summarize this for you. So this is the evidence, current evidence. So infliximab was licensed for use for refractory sarcoidosis in the UK a few years ago, very much based on what evidence we have. So people usually have a favorable treatment response. Over 80% of people who are refractory to all treatments respond very well to infliximab, almost achieving complete remission in 50% and partial remission in a third. In terms of clinical improvement with this, there's certainly a complete neurological recovery. As I said, majority of people are actually doing pretty well on this. But again, bearing in mind that, going back to my step analogy, as you go up the step, you basically accrue toxic side effects. And hence it's very important to kind of think about how we monitor patients on treatments as such. Again, another study which went on to look at a very similar aspect, again, went on to just say that infliximab is a very important treatment and got a significant role in people with refractory sarcoidosis in achieving that complete remission in about a third of patients who've been initiated with completely disease-free within that particular role. Now, I just wanted to, before sort of the last few slides before we finished, I also wanted to kind of talk about this, which is a little bit of work which we did looking at treatment outcomes of patients when we did certain phenotypes of patients with sarcoidosis were just given corticosteroids alone, as opposed to people given steroids with azathioprine and infliximab. And what this upper part of this particular graph actually sort of, ables out is that actually there was a very significant difference between people just treated with corticosteroids alone as opposed to people triple treatment. Really to highlight that corticosteroids and lower step treatments are not sort of one sort of glove fit all type of situation. Really, there are patients in whom there's a significant superiority in treating people with higher level treatments, and particularly combination of those treatments when compared to single treatments. So factors that influence the choice from our perspective is really steroids are favored in patients who plan pregnancy, kidney and liver disease, limit their use. Rapid disease control is needed, and symptomatic treatment for acute conditions is needed. And of course, when people become either refractory to steroids or we worried about steroid side effects, which is very important to think about, or there's organs are involved and we need long-term treatment, then we would move towards the steroid-sparing agents, such as the Methotrexate and the Isotope and the mycophenolate. My last slide is, I'm sorry, slightly over time. So in terms of the last slide really is to talk about the non-organ manifestations of sarcoidosis. Now, in all the people with sarcoidosis we treat in our clinics, I cannot think of the last patient who came with a normal, with a scan which had sort of got significantly better, who essentially came in and said, actually, I don't have any fatigue. I've never had neuropsychological involvement. And that is extremely important to recognize. So these are all the hidden parts of sarcoidosis. So no scan is going to be able to pick up fatigue and neuropsychological symptoms, but it is a real situation. So it's very important to recognize that, because the impact on quality of life is essential in order to achieve that optimal treatment for patients. And the MDT role, again, the center of my ABCD, which is MDT role, which is physical therapy, empowering you as a patient, is really important. And providing the psychological support in order for you to be able to fight that fatigue and mood disorders, which plays a very much more significant role to your whole disease in the way you can work and function and carry on. I think it's really important. So MDT is really vital, and I cannot sort of stress the importance of that sort of enough, really. So I think that was all I was going to talk about today. So essentially sort of pinning down. So thank you, and happy to take any questions later.